請政府嘅。
All right, this is the appointed time. We have a quorum. Let's invite the administration in.
好，咁
Let me wish everybody, including representatives from the administration, a Happy New Year. And we have received a paper from the administration about the issue relating to the participation of mentally incapacitated person, MIP, in the EHRSS arising from the discussion last time. And Dr. Fernando Zhang is particularly interested in this topic, but he is away at the moment, so perhaps we should wait for him to come back first before we go back to this paper. So let's continue with the cost-by-cost scrutiny from last time. I think we're in part 3, clause 12. Is that right? Please continue. Thank you, Chairman. I wish members good health as well. We were on Division 3, Clause 12, sharing consent. Now, the design of the system is that after giving a sharing consent or joining consent, the patient may give sharing consent based on the prescribed healthcare providers of the recipient's choice. And Clause 12 states that the consent can be given by the patient or the healthcare recipient himself, or if the healthcare recipient is a minor, then the sharing consent can be made by a substitute decision maker. And the 12 subsection 4 says that the SDM making the sharing consent should be should have regard to the best interest of the recipient in the circumstances. Subsection 6 details of the consent. Now, once the consent is given, the prescribed healthcare provider can provide to the system any shareable data of the healthcare recipient and to obtain from the system any shareable data of the healthcare recipient, and in the course of treatment provide such data to another healthcare provider for referral. For example, when it comes to a lab test, the result may be shared with another clinic, and bracket 6A3 here means that shareable data can be provided to a referral healthcare provider. And here, a referral healthcare provider commonly means a laboratory, because after conducting the test, the result would be uploaded to the system, and B1 says that in the form and manner specified by the Commissioner, the data can be provided to the system. Now, as far as the recipient is concerned, we must also allow the referral healthcare provider to obtain from the system the data. Now, this is for bracket 6. For bracket 7, it states the sharing consent must be given in the form and manner specified Maybe some forms will have to be filled out. Bracket 8. Now the healthcare recipient can choose among the two, that is either to give a sharing consent for an indefinite term or a 1-year term. That is basically about clause 12. Any questions from members? Dr. Kokaki? Chairman, I have a question for Commissioner. Now, there is a choice of a 1-year term. Let's say if within that year, if the patient would like to change his decision, let's say 3 months later, he may wish to change his decision so as not to allow the laboratory to access his data again. Then would there be a mechanism for the sharing consent to be ceased? Let's say, for example, there may be a number of referral healthcare providers, physiotherapists, Chinese doctors, etc. And the patient may choose to give consent to A and B and not C. Does it mean that in a short period of time, the patient may choose to change his decision on any combination of consent to be given without waiting for the expiry of the 1-year term? Well, let me give you an example. Say if there are 5 healthcare personnel involved, maybe physiotherapists and other personnel, then if consent is going to be given to the first 4, then the 5th one, of course, will not have access, and the patient can choose whether to give an indefinite terms consent to the 4 providers. Now, if the patient then loses confidence in the first 3, then the sharing consent can be withdrawn in relation to the first 3, whilst the consent for the 4th one remains. Now, we've included the option of giving a consent for an indefinite term or 1-year term because some patients may only wish to give a sharing consent to a healthcare provider for a short-term purpose, maybe for cosmetic surgery. That 3 months consent would suffice. If indefinite term is chosen, the healthcare provider may be able to continue to access his information, and that is why we've included the option of 1-year term. Actually, for clauses 13, 14, they seek to explain the difference between the indefinite and 1-year sharing consent. In fact, clause 13 includes if a patient has flexibility in choosing indefinite consent, then the patient may choose to give a 3-week consent or 3 months consent. So that means after giving indefinite sharing consent, the patient can withdraw consent. What about 1-year sharing consent? The patient can still choose to change his mind to shorten the sharing consent period instead of 1 year. Yes. Yes, please go through clause 13 as well. Now, clause 14 is about 1-year sharing consent. Bracket 8, is that right? Now, theoretically, the sharing consent should take effect within a 1-year period. But under the circumstances in A, B, and C, the consent can be withdrawn.
Now, how does one know to whom he or she has given the sharing consent? The person might have forgotten to whom he or she gave the consent, and then he might want to revoke the consent. Can he go on the internet or make a phone call? Now, he may have patronized different doctors over the years and added new doctors or cease to patronize certain ones, and if he forgets, he can contact the EHR office, and we will tell him. So he just contacts the office? Yes. Now, if we use a system for customer service, that would be much simpler. Maybe you can't do it right now. Maybe there can be a mechanism in the future for a patient to check out to whom the consents have been given, taking into account additions and removals. Otherwise, you may have a lot of work involved in answering phone calls. Thank you. I think Ms. Quek is thinking along our lines. As the system develops, more and more patients will join, and each person will make a lot of choices. So we hope that in the second stage of our development, we can have a patient portal so that the patient can go onto the system and he can amend his consent, and he doesn't have to go through our office on every occasion. So that's in stage 2. And the patient might be able to view some of his own health records. And we mentioned the safe deposit box, so that might also be part of that mechanism, right? Your colleagues have been nodding, right? When we come to clause 16, we will talk about those provisions on the safe deposit box. Now, we don't know how the design will eventually be. Now, the patient will be able to express his views on which data to be shared, and of course he can also come to our counter. Dr. Fernando Chung, you will not be leaving soon, because we like to come back to your part. Now, on clauses 13 and 14, we have started those two. Maybe we can finish on clauses 13 and 14 first. Now, it's been just mentioned that the design is such that when a patient gives a sharing consent, it can be indefinite, clause 13, or 1 year, clause 14. Now, the indefinite consent 13 bracket 2 says that it will be effective until either the system, the person withdraws from the system, or we might cancel the registration for whatever reason. Perhaps he used a false document or other reason. Thirdly, he revokes his registration on his own initiative. Now, for the 1 year sharing consent, it's basically the same. Under clause 14, 2, 3, 4, 5, 6, the wording is similar. If it's a minor, then the consent can be given by the parent. If it's a mentally incapacitated person, it can be done by the substitute decision maker, and the SDM will consider his best interest. The wording is similar to those in the previous clauses. Any questions by members on this part? Sorry, actually I have a question on the previous part and this part. Now, on the referral healthcare provider, are there any limitations? No. Now, is there some limitation on who can become a referral healthcare provider? In 12 bracket 9, we offered a definition for referral healthcare provider. Firstly, he must be a registered healthcare provider, and in 6A, brackets 3 and 6b bracket 2, we said that the information referred has to be relevant to the healthcare provided. It cannot just be any kind of information. The person has to be within the scheme, and the first doctor who disseminates the information to him has to provide information relevant to the healthcare. And on clauses 13 and 14, now, is there any provision that deals with the case where the patient himself, say, may die, and then what will happen with the information in the system? How will that be dealt with? Maybe there is another provision somewhere else that deals with this. I believe that's somewhere later in the bill. So that covers, there's a provision that deals with the case of death. We will come to that. Any other questions from members? Perhaps we will come to the document, and then before we go to clause 15. That document, I believe, has been received by Dr. Cheung. That is the issues when mentally incapacitated persons joined the scheme. We finally gotten the replies from the Labour and Welfare Bureau. Now, in the past two meetings, Dr. Cheung mentioned that under certain conditions, and there may be an MIP without a guardian. In that case, it's very difficult for a decision to be made to join the scheme, and it was asked to whether the guardianship board under the Bureau can appoint a guardian for this purpose, and we asked the Labour and Welfare Bureau, and I believe you have received the document. LWB basically says that the guardianship committee, when considering appointing a guardian, is very restrictive. There are only 6 types of situations where major interests involving a person is involved. Would a guardian be appointed? Because the guardian is exercising a decision instead of that person. So it must be very important. Maybe it's medical treatment or a serious decision regarding his property. Now, in respect of our scheme, the guardianship committee doesn't feel that our cause is not so important that they have to expand the scope of their work to cover this situation. So they didn't intend to amend the powers of that guardianship committee to include our cause. And also, it's been mentioned last time that even though the guardianship committee doesn't want to appoint a guardian specifically for this reason, it's for the family members to decide, and then it's asked whether the committee can be the adjudicating body, and then the Labour and Welfare Bureau again replies in the same way. It depends on whether the situation is critical, and whether the committee should join the scheme. On that they think the matter is not so important that the committee should expand its role. So they do not intend to expand the scope of their work for our purpose. Dr. Fernando Cheung, of course, I understand the Labor and Welfare Bureau's response is basically that it doesn't want to budge, but my query is still valid. Now, this whole measure, this whole bill is beneficial. It's so that patients can share the health records electronically, so that doctors in different sectors can make use of those data, and healthcare providers can get more information as a result, so that they can offer better diagnosis and service to the patient concerned. Now, this is something beneficial, so we hope that all who can make a decision for joining, and the decisions for retrieving data and when to withdraw from the system, and which data should be in the safe deposit box. Now all those decisions, we think, can be made voluntarily by the person concerned, but we know that there are certain persons in society that are incapacitated, including those who have been adjudicated MIP by the courts according to set procedures. And then there are certain persons who number quite significantly, and they may live in certain institutions, and they have cognition problems, so that they find it's very difficult for them to make the decision voluntarily and on their own initiative. So under this bill, it's very difficult to convince this committee or me how we can make this bill work for these people. So we try to plug this loophole in the bill, but the Labor and Welfare Bureau comes back and says we don't want to move. So the problem is not resolved. Now, let's take many steps backward. Now, if we can do it under legislation, maybe in future administrative guidelines or future administrative measures, you can take care of this loophole. Now, these people who may be adjudged by the courts to be MIP or pseudo-MIP, now can there be administrative measures so that somebody will make decisions on their behalf in respect of electronic health records? And when there is controversy, what can be done? Now, I think these issues are very basic. Now, the bill is to try to benefit all people, especially the disadvantaged groups who have special needs. Now, you say under the bill there's nothing that we can make the Labor and Welfare Bureau do to change their mind. Now, if legislation cannot resolve the problem, is there a way out administratively? Whether the medical sector or the welfare sector, for instance, a caseworker, whether it's within the Department of Health or whatever, so that you can assure us. Now, we know many disadvantaged groups do not benefit from this bill.
Now, Now, the Labor and Welfare Bureau says that according to the Mental Health Ordinance, nothing can be done. Well, they mention 6 powers. I think that those are not really reasonable. It's about seeking medical consultation. I don't think this is not similar. So I follow Dr. Zhang's point. I don't think it's quite reasonable. Anyway, we're dealing with this bill, so the question is whether in the future we can make use of the guidelines and prevent such from happening. That is, to prevent MIPs from not being able to enjoy the privilege of joining this scheme. Thank you, Chairman. The intent of the bill is to allow some who can make decisions on their own to join the scheme, and for those who cannot make decisions on their own, we allow SDMs to make decisions for them, such as child in the situation of child and a parent. So for those eligible SDMs, maybe it's a guardian appointed by the board or family members. Now, if not even a family member exists, then the healthcare provider will be eligible. But in deciding whether to join the scheme or not, one should have regard to the best interests of the healthcare recipient. We believe by drafting in such a manner, we should be able to cover all scenarios, because after all, the scheme is a voluntary one. If this is based on voluntary participation, it is unreasonable for an SDM to decide to let the healthcare recipient join against the patient's will. So last time we also discussed the different views of family members of the healthcare recipient. In fact, even with or without the scheme, at present, the HA also faces a similar situation. One family member may opt for the procedure, the other may go against it. So when such a situation arises, well, the district social worker would help in mediating the situation. Now, if the family is not familiar with the new system or the new scheme, then of course we're responsible for explaining to them the benefits of joining the scheme and who will be eligible. Of course, we cannot change the powers of the guardianship board by this bill. And as for the suggestion of doing something administratively, yes, I think first of all we can give internal circular or guidelines to staff of the HR office that in the event of 2 different family members holding 2 different views on whether to join the scheme or not, then our staff on the spot will try to explain to them the benefits of the scheme. Now, if a consensus cannot be reached, then we don't want to put a stop there. Our staff would follow up on the case. Say if there is a dispute in the presence of our staff members, then in 3 weeks' time or in 14 days, our staff members may ring the family members and ask if further clarification is needed. I think this is what we can do internally in our office administratively. And secondly, For all healthcare providers, be it private hospitals or clinics, we're going to give them, we're going to issue the code of practice, which is advisory in nature. And we would advise them then that if there are two qualified SDMs holding different views, what should be done? Because the SDM is required to have regard to the best interest of the patient, then at least the healthcare provider can do one thing, that is to determine which is in the best interest of the patient. And this can be explained to the family members of the patient. Yes, this can be done administratively as well. I think this is more or less what we can do. Dr. Zhang. Alright, this is about handling family members with different views. I'm not talking about the views on whether to join the scheme or not, because after joining the scheme, you still have other decisions to make, such as the safety box, such as retrieving e-records or withdrawing from the scheme. We cannot assume that there will never be any disputes over these matters. There could be. We don't know whether there could be differing views among family members on the issues I mentioned. We're talking about settling the matter in an informal manner. As to whether this is the best solution, I don't know. I think it's just so-so. Anyway, putting this aside, I have another point, because these patients may not know how to join the scheme by themselves, and it's said that if they are MIPs, the SDMs can decide for them, and there are many SDMs. For an elderly person living in a RCHE, the family members may have emigrated, and in the RCHE there may be a resident doctor, nurses, attendants, so on and so forth. All of them could be SDMs. So who would take the initiative in deciding for the patient? Now, it won't be put in a bill. Will there be an administrative guideline issued to them to designate somebody with legal responsibility? Otherwise, everybody could be the patient's SDM, and yet these people may not take the initiative in even considering making a decision, because nobody is in charge. So there is this group of patients for whom there is nobody to make decisions. Can you give a guideline for in this regard? Well, we discussed that last time actually. Let's say if a patient has 6 family members, and if the patient lives in a nursing home, basically the nursing home as well as the 6 family members are eligible to become SDMs. If any one of them gives serious consideration of whether to join the scheme or not, then that is all right. But Dr. Zhang's example is where none of the family members does anything, nor does the home, then what should be done? But our consideration is this: as far as the law is concerned and the guidelines are concerned, we cannot require anyone among the 7 persons mentioned just now to make a decision for the patient. We cannot mandate anyone to do that. We don't know what's inside these parties' head, whether they considered anything at all. What I can say is that in the event of disputes, we can only advise in the guidelines that the relevant individuals, including healthcare providers, to give regard to the best interest of the patient. So, if you're concerned about elderly patients being put in a home by himself or herself, then basically we're talking about two groups, elderly people and children. Well, elderly people often visit public or private hospitals, and our plan is to visit these care homes so that these homes can be their SDMs. And in fact, in our pilot scheme, some 400 homes have joined. And these elderly patients under the PPI-EPR scheme are interested in joining the scheme. So we're going to do more in terms of promotion and explaining to the homes. Now, Chairman, of course, I understand that you cannot compel anyone in the law to make decisions. However, Mr. Chan just now said that in the future you cannot specify the responsibility of anyone in the guidelines. I don't quite agree. Of course, you said that in the pilot scheme many homes have been quite proactive, but we cannot guarantee that the attitude will remain the same in the future. Many parties are involved, RCHDs, subvented and private ones, special schools. Would all of them be proactive in helping such a group of patients in making decisions? Of course, the decision is not a matter of life and death. It's just about joining the platform. Yet, it's still in the interest of patients. So, I hope there is a system or a mechanism that can be put in place to ensure that consideration has been given as to whether the patient should join or not. Well, actually, you're repeating, and Mr. Chan, just now you mentioned whether it's possible to give strong advice in your guidelines and remind residential care homes to give consideration to that. And in fact, this is not binding. This is just a set of guidelines. Anything to supplement, Mr. Chen? I won't use the term guidelines because, as I said just now, in the first year after the scheme is implemented, we're going to do some publicity. We're going to issue letters to homes that have either joined the PPI scheme or not, to explain to them the benefits of the scheme. And we're going to take a proactive approach as far as publicity is concerned. However, administratively, it is difficult to include that in the guidelines or in the bill. Yes, it's not provided in the bill. Dr. Zhang is not making this suggestion.
This is not quite possible. Now, Dr. Zhang, maybe we can let Dr. Leung Ka Lau speak. Maybe can I just add one word? Now, the private institutions, you can't resolve that. Now, for the regular hospitals, we can issue guidelines to remind the medical health social worker or some healthcare provider with a social worker, that there is a procedure to check whether such persons have joined and whether somebody can make a decision. Well, it takes a long time to respond. Perhaps Leung Ka-lau can speak first. Now, on SDM, at the first couple of meetings, the issue was already raised. Now, Dr. Cheung said that some family members may have some dispute about who will make the decision, so it may be troublesome. Now, some family members, we don't know what they really thinking about in their mind. So at the meetings, it was asked of the administration whether it can follow the SDM arrangements in other medical procedures. Now, the current arrangement is that if the patient is incapacitated or has lost consciousness, then it's the doctor who cares for him who would act and make a decision in the best interest of the patient. Now, this is the current practice. Now, this practice, will it be evaded by the doctors concerned? The answer is no. Because if one doesn't make a decision on behalf of the patient, on their behalf in their best interest, then later the family members can fault the doctor for that. The doctor has to be responsible. So, over half a year ago, we discussed this. Now, can the SDM follow the provisions for the legislation on mental patients, i.e., in such a case, the doctor who cares for the patient will make the decision. That will resolve the problem as raised by Dr. Cheung. Now, this was raised several months ago, and we provided a written response. We think we have to distinguish between the two. Now, if it's a curing process, if it's a medical treatment, then in emergency cases, the doctor can make the decision first in emergency cases. But here we are not talking about a treatment. We're talking about whether to join a scheme so that the health records can be shared. It's not so critical that a major consequence would arise if the joining decision is not made right away. So we're saying that these persons are qualified to become an SDM, and ultimately, and in the end, we mentioned the healthcare worker at the end, but we are not saying that the healthcare worker has a higher obligation, or when we didn't state that there is a critical need for the doctor to make a decision. Dr. Leung? Now, the current practice doesn't state that the decision is to be made only in an emergency situation. There is no provision on emergency. Here, they're talking about whatever situation. Now, I'm only talking about the current practice. When a doctor has to make certain feels that a decision has to be made and the patient is incapable of making that decision, then the doctor will act in the best interest of the patient and make the best decision possible, and no mention of emergency situation is made. Now, under the bill on the giving of sharing consent, now on joining, the SDM can make a decision. Then there's also the sharing consent. There's also an SDM arrangement. Now, on the sharing consent, sometimes it can be a matter of emergency. Now, so the decision has to be made for a patient to receive treatment. It may be a critical situation. Mr. Chen, now we explained this in our written reply. Now, even if it's an emergency situation under current provisions, legislation, the doctor can already look into the health records. It doesn't have to rely on the sharing consent. So in that case, you can state in the provision that the healthcare provider, well, the healthcare provider is not limited to the doctor. It can be a residential care home. Now, the bill doesn't say that under the privacy ordinance, now on the SDM, apart from A, B, C, D, E, you didn't say, you didn't mention that this fact that the in emergency situation, the doctor who provides the care can look into whatever health records available. Well, even if the scheme was not joined, the doctor can still do that. It's already written in another piece of legislation, not in this legislation, but in actual practice. There's a privacy ordinance provision, and if the doctor who thinks he's responsible and thinks that there is a need, he can open the records on the HRSS and also in the records of the institution. Ms. Chen, will you need to respond? I think the head should respond. Would you like Dr. Cheung to repeat the point? Well, you have to repeat on the last point. Dr. Cheung, I'm concerned about this. Now, you said that it's not possible to state in the guideline to ask that a person to consider the matter for a patient. Now, I don't think that's impossible. Now, in a regular service system, there can be provisions in the guidelines asking persons in those positions to at least confirm whether somebody at some point made a decision on behalf of that patient. So the purpose is so that there wouldn't be any omission. Now, the law says that the MIPs have these SDMs, but in reality, very few people would be formally defined as MIPs. In most cases, there has been no such determination. Now, an elderly person may be in an elderly home, but no one has determined who will be his MIP out of his relatives. So the healthcare provider is that provider authorized to make the decision on behalf of the elderly person. That's not possible. So the family members have to be located and to give the consent. Maybe the family members are not available, and the elderly person has not been determined as an MIP, and the elderly home cannot, under the law, become an SDM on his behalf. Otherwise, the family members later may hold the elderly home responsible. So this, when there is no formal determination of the SDM, then the SDM provision will become ineffective. How can we help the patient in this case? Maybe I can try to help. Now, if you say, Mr. Chen, that issuing a guideline is difficult, then if you say very clear in your public education that you strongly request these residential homes to help these elderly persons now to do the best to try to contact the family members. Now the Labor and Welfare Bureau is of no help in this case. So can the head of the EHRO give an answer? Now, can you follow up so that the members can be more assured, so that no one is left without anyone to care for them? Now, under 12(3) and on sharing consent and on the provision on joining consent, now we are saying that a person of age 16 and is unable to make a decision, that's the person we're trying to help. He doesn't have to be formally adjudged an MIP. Maybe he is too weak physically to give a consent. So it's broader than MIP. So if someone hasn't been formally determined to be an MIP, but he is not capable of making the decision, then the SDM is able to decide on his behalf. And secondly, can we do something more in the guidelines or administratively so that someone who we consider should join the scheme for their benefit has somebody to make a decision on that person's behalf. Now, we may not know who to look for. If the patient lives in a certain person's home, we don't know which person. But if he's in some kind of residential home, then we can do more publicity work with these elderly homes or residential homes, and we can urge them to take the initiative to urge them to make such decisions or identify the elderly persons who are unable to make such decisions. Now, our scheme is open all the time. Now, this person may be healthy right now, but in 6 months, that person may be very weak or unable, do not have the capacity to join. And we don't think it's necessary to make it mandatory right away.
都係咁嘅答案。
Well, Dr. Zhang, well, I think they're just giving you the same answer. So let's not waste time. So the law cannot be changed, and you cannot put this in the guideline. Administratively, what you're going to do is to try your best at publicity or public education. I'm not happy with that, but I think I will just take it for the time being. Yes, let's wait and see if there are better solutions in the future. Right. Legal advisor, you have something to supplement? Yes, thank you, Chairman. I want to point out to members that the government mentioned just now, that in relation to the scenario raised by Dr. Leung, there is no need to deal with that in this bill, because in the PDPO there is an exemption in relation to emergency situations, because this has been dealt with in the Personal Data Privacy Ordinance, and there is no need to amend this bill. And I think he is referring to 63C. But on reading it, I don't think this is relevant. Well, let me briefly quote that for members' reference. In relation to the collection and use of personal data, if the following things may be infringed upon, and those are, first, in identifying the person's identity who is in the life-threatening situation, and secondly, to inform the family member of the persons in such a situation, and thirdly, provision of emergency services or rescue services. And under such circumstances, exemption would be granted under the PDPO. Now, I don't see how this can apply to the decision of joining the scheme or giving sharing consent. So it doesn't work. Mr. Chan or anyone from the DOJ, would you like to respond? Now, for 63C and 3, our view is that basically it covers the scenario mentioned. Of course, we don't have 63C at hand at the moment. Do we need to make photocopies for members? Because this is from another piece of legislation, the Personal Data Privacy Ordinance. So the legal advisor's comment is that in the event of emergency situations, under the PDPO, a doctor still cannot make a decision for the patient to join on the bill. Well, I'm just reading it and interpreting it literally. There are three scenarios. First, on identifying the patient's identity, and second, informing the individual's family members of the involvement in the life-threatening situation, and thirdly, in carrying out the emergency rescue operations and provision of emergency relief services. So please explain to us how this can apply to the situation. Well, we're talking about the access of records in emergency situations, and there are exemptions under the Personal Data Privacy Ordinance. We're not suggesting that the healthcare provider can give consent on their behalf in such situations. We're talking about accessing the data, because disclosure of personal data is not allowed unless there is consent from the data subject under the PDPO. And that is why in this bill we have this consent arrangement for disclosing personal data and have them uploaded in the system. And Dr. Leung just now mentioned that in emergency situations, no sharing consent is needed. We can rely on the relevant exemptions in Section 63C of the PDPO, namely under 1C, in carrying out emergency rescue operations or provision of emergency relief services. Exemption could be given, and that personal data may be accessed. It's not about giving consent by the healthcare provider on behalf of the patient. You're talking about emergency situations. Yes, Section 63 1C. In carrying out emergency rescue operations or provision of emergency relief services, personal data is exempt from the provisions of data protection principles. That means the healthcare provider can have access of the personal data in the system. It's not about sharing consent. It's not about giving consent, right? It's about requiring no consent at all. Legal advisor? Legal advisor is still thinking about that. Let me go back and mull it over, because Dr. Leung is talking about the healthcare provider being an SDM, and Dr. Leung mentioned that even as of now, emergency situation is not a consideration, and the government says that there is exemption under Section 63C. Now, let's say I'm taking care of a patient who is unconscious. Now, if the patient is sober, of course I'll ask the patient first whether or not it's urgent or not. But if the patient is unconscious, my understanding is that emergency is not a factor, because we can't ask the patient anyway. Now, about the exemption under PDPO, the healthcare provider is accessing the data and not in the capacity of an SDM. Well, still, now as far as the existing arrangements are concerned, well, it's not that no consent is needed. The healthcare provider is an SDM. As far as medical treatments are concerned, it's not really the case that no consent is needed. In fact, the healthcare provider is an SDM. Now, would Mr. Chan please clarify what that means? We're talking about a number of things. The SDM in this bill makes a decision for those MIPs whether to join the scheme or not, and to choose which private clinics would have access of the shareable data. So this is what the SDM in our bill should do on behalf of the MIPs. Now, we've talked about different scenarios. And let's say in an A&E unit, a patient may not have joined the scheme, and maybe there isn't enough time to check if the patient has joined the scheme. Then should a doctor be able to access the data? Now, under the PDPO, there is an exemption. As far as emergency relief services are concerned, no consent is needed. Now, Dr. Leung then extends the analogy and says that if the patient is unconscious, maybe it's not in an emergency situation, the doctor would still need to decide what treatment to be given to the patient. And then we have different scenarios. For example, if the patient is unconscious and if there is a family member present. But while there are different scenarios, even with family members present, they may hold different views. If the view of the family members are unanimous, then you must follow the view, right? Well, as a doctor, I don't need to hold the dissenting view, right? But if there are different views from family members, then the doctor would have to make a decision, right? Because under the existing arrangement, if I recall correctly, the doctor is an SDM under the Mental Health Ordinance, not under the PDPO. Under the PDPO, the doctor is not regarded as an SDM. He is given exemption, but I'm talking about the doctor being an SDM under the Mental Health Ordinance. Right, so that's the SDM under that ordinance, but not the SDM under this bill. Because under different ordinances, the decision concerned may be different. But in the course of a medical procedure, whether you want to check the data or not, I think there should be consistency as far as SDMs are concerned. But different ordinances regulates different decisions. No, right, we're talking about different decisions under different ordinances. Dr. Leung emphasizes treatment, whereas we are emphasizing the decision on whether to join the scheme and to give consent or to select the hospitals and clinics to give consent to. I think the legal advisor would go back and mull over the issue as well. Well, I recall that when the exemption under Section 63C was introduced, we were talking about the use of personal data in the event of the family members not available. If the government thinks that the exemption also applies, then would you go back and do some study and give us a written response so that we could go deeper? Well, in fact, we did look at the issue, and maybe we can confirm with the Privacy Commissioner. Anyway, we're talking about two issues. First, who should be the SDM under this bill, and who should be able to make decisions on behalf of the patient to join the scheme, and what clinics or hospitals should be chosen. The second is whether under emergency situations consent should be given before the record can be retrieved. And the answer is no. Treatment could be proceeded with right away without getting consent first. Maybe the legal advisor can go back and think about that, and if she still finds that there are outstanding questions, and put them down in writing for the administration to give supplementary information. All right, this is CB bracket 22187 slash 1314 bracket 03 about the priorities of SEMs and retrieval of records in emergency situations. Both papers are responses given after a meeting in June. Maybe next time the legal advisor can revisit the same issue if she still finds that there is a problem. Let's go on with the clause-by-clause scrutiny. Clause 15 is about revocation of sharing consent. The healthcare recipient, namely the patient, may revoke a sharing consent given to a healthcare provider, say a private clinic. If there is an SDM, the SDM can decide on his behalf the revocation to be made. The provisions are similar to the previous ones. There should be regard to the best interest of the recipient. It should be made in a form and manner specified by the Commissioner. So that's about revocation of sharing consent, clause 15.
Now on clause 16, I'm sure there will be some comments. It's about the hospital authority and Department of Health getting special treatment. Now, there are two parts. First, the patient decides whether to join the scheme. This is the joining consent. And after the patient joins, he has to choose which private clinic or hospital would be given the sharing consent. Now, but as for the HA and DH, it's a bit different. Now, the patient can choose to join or not, but once the person joins, he would be regarded as having given the HA and DH sharing consent. This is an automatic sharing consent. Now, 16 bracket 1, 2, 3, and 4 explain this. Now, in the past, members asked why there is such an arrangement, why the HA or DH is not treated the same way as a private hospital or clinic, whether or why the patient can be given the option. Now, we have already provided a document, I believe it was in July, and let me repeat. Now, here we are talking about encouraging the sharing of health records between private and public healthcare sector in the interest of the patient. We think that would offer the best to the patient, and this what's happening now is that the private this unidirectional, this one-way consent is already in existence. Now 400,000 patients already benefiting. Now we would like to take this in the other direction, so that the private doctors can have access to the public health records. That's why we use the public money to build such a platform to share the information. Now, that's our initial purpose, and it's in the interest of the patient. Now, in our own steering committee, where there are representatives from different sectors, and when we conducted public consultation, we stated this practice, and this is in the best interest of the public, and it's the HA and DH who take care of most patients, and they take care of the most patients. When a child is born, when starting with his first vaccinations, all along the health records are accumulated. So that was our initial belief, and that's why we have this design today. You can choose whether to join. Then, the HA and DA will automatically have access. Now, okay, I believe there is no problem on 16. It has been discussed previously, Dr. Leung Ka-Lau. Now, on clause 16, if we delete the entire paragraph, would it be prejudicial to other provisions? If I propose an amendment to delete the paragraph, now on whether the HA and the H have the power, now would it prejudice the logic of the provisions in the bill? Now, you propose to delete the whole paragraph. The DH and HA will not automatically get the sharing consent. Now, will there be a need to amend other provisions? It will have a serious impact on our system because the design of our system, and we have explained initially, is that the design is such that once a person has joined the scheme, then the DH and HA will build a file for this patient, for this person, and this arrangement is automatic. If we take out this paragraph in section 16, then the system cannot operate from day one. So are you saying that once this is deleted, you have to withdraw the whole bill? Now, we operate by the power given to us, the scope of the power. Now, here a power is given. If the patient has joined, then the HA and DH will immediately have access to the health records of the patient, and this is what the system revolves around. If you take this away, we do not have the legal basis. I don't understand. The government has been saying from the outset that technology is neutral, and well, when they talk about technology being neutral, I think that's different from the design. The design is the design assumes that HA and DH have access. No. It's only by this paragraph that the DH and HA can upload the data, not download. They're saying that DH and HA have the records of many patients, and only when this consent is given can the data be automatically uploaded. Let me explain. Suppose a private hospital, say we call it the Queensway Hospital. Now, if the patient has given sharing consent to Queensway Hospital, then the hospital can put the patient's records loaded onto the system, and it can also read the patient's records in the system. This is the sharing consent, allowing the private hospital to do these two things. Now, what we are doing is that for DH and HA, the patient doesn't have to specifically give the sharing consent. Once you join the scheme, the patient would be regarded as having given consent for the DH and GA to upload your data onto the system, and also to have access to the records on the system. So once a patient joins the scheme, the design is such that the DHA can have access to whatever records of the patient on our system. It would be included in the file of the patient. Now, this is mainly because you have already a very large database, and also the largest number of members of the public are under the care of the DHA. So uploading the data is a right, and reading is another right. It's a different right. Usually reading and uploading are different, but now you are taking the two together for the patient. So the patient doesn't have a choice. Both read and write are taken together, written into the bill. Okay, I'll go back and think about whether I can allow you to do this, but it seems that by deleting the paragraph, the rest of the provisions in the bill will not be affected because no other provision makes reference to this paragraph. Also, you said that in your previous consultations no one objected. Now, I asked my colleagues in the Medical Association, and they said that they have no such impression. They said that they don't recall such consultation. Now, can you provide some information on when did you ask them, and whether there are meeting minutes that can be disclosed to see whether this matter was discussed previously or maybe it was overlooked? Or there are different members of the Medical Association. Now, several members who took part in meetings said they have no recollection of such discussion. Now, perhaps the administration can later provide information when did, where in the consultation document was this mentioned, and when did those concerned give the agreement, or maybe they didn't think about it and they didn't pay attention, or maybe there are minutes in the subcommittees of the Medical Association. Mr. Chen? Now, there are several stages. Now, first, our steering committee and their working group studied the system in its entirety, and they discussed this arrangement. And there are Medical Association representatives in these meetings. Now, many things are discussed, but I'm sure it's been discussed. And secondly, even if it's not in the drafting stage, later we did write that into a consultation document, and that was read by the public. Now, I only have a summary version, and it says that the offering of joining consent includes the agreement for the HA and DH to be able to share the data, to upload the data. Now, the medical groups and the IT groups and the public all were able to read this. Now, at the request of Dr. Leung, do you think you can go back and find some records of participation by the Medical Association? Now, very often, maybe people didn't notice and they didn't express any views. Well, in any case, you can make a comment and offer your views now. Well, it seems that I'm not being allowed to. Well, you are not being stopped from making this comment.
Well, at that time, different organizations gave us views on our design, and some may just remain silent. We don't know whether they're for or against it. Any way you can retrieve the records, well, as to who supported and who opposed, maybe their views have changed today. So we need to, the most important thing is what they think of it now. My point is this: if you want to change it, I can't change it in phase one. I already said that if someone, for some reason, says that he only see doctors in the private sector, private hospitals and clinics, and not the DH and not the HA, then he can, at the very outset, choose not to give consent to joining consent to HA and DH. And he can give consent only when he visits the HA and the DH's clinics. This is what I can think of. I think Dr. Leung is particularly concerned about the medical association. No, not really. Because Mr. Chen very often quoted the example of the medical association. That's why I did the same. So if you want to know what the view of the medical association was then, that's one thing. If you're talking about the medical association not really being informed of the consultation, not being able to give their views, maybe today they have, you can ask for their views again. I don't know whether there is any difficulty in retrieving such a record, or if indeed there is a record. Now, the second question is, despite the consultation, what is the view today? If Dr. Leung still thinks that it's not desirable, we can't change it day one, but we can change it later. So the question is whether Dr. Leung would agree that when it comes to phase 2 in the consultation exercise, this question can be posed. That is, clause 16 can be scrapped so as not to give joining consent to HA and DH. Whether this can be part of the consultation in the second phase. Let's see if you're happy with that. I'm sorry, but do you have anything in black and white? I think they had this paper previously. You raised a point before, so I suppose they have this paper. 2308/1314(02). 2308/1314(02). I don't want to waste too much time since we're doing clause-by-clause scrutiny. I think we're still going to discuss whether any member would move CSAs, and by then we'll need to seek other members' views, whether the CSAs should be moved by chair of the BC or not. Well, yes, maybe later we can point out which paragraph in this paper mentioned just now for Dr. Leung's reference. In fact, a reply has been given in black and white. Dr. Lloyd Kwok next. Thank you, Chairman. Dr. Leung Carlisle is a doctor by profession. Of course, we need to respect his professional or expert view. But this is already the I think we've come to this stage. If we're still talking about principles, then I think this is quite peculiar because we're talking about e-health record sharing system. So it's about sharing. When the BC first started, we already had quite some discussion on the concept of sharing. Once you make the choice, the data will be shared. Of course, safeguarding the patient's privacy is another matter. But if the data cannot be shared, then the system cannot really be functional. So, if we are to challenge the fundamental principles, again, I think we will see no end. On Dr. Leung's question, I think the government should give more information. He said that it's all right to strike out clause 16 because there is no cross-reference in other provisions. But I don't agree. I agree with Mr. Chen that this gives legal justification for data to be shared. Once you join the scheme, you're giving consent to the DH and HA for data to be shared. That is for the healthcare providers joining the scheme. So it's a matter of sharing data. Now, Dr. Leung also asked a question on the provisions that in the bill that actually refer to Clause 16. So would the government please answer this question? I agree very much with Dr. Low. Scrapping Clause 16 doesn't just mean a paragraph less in the bill. It will change the whole system. Public hospitals can rely on this as the legal basis for uploading information in the system. Without Clause 16, they can't do that. And this is the outcome of a consultation done years ago. Well, about retrieval of record, let's say I think the use is limited. If there are organizations that have given their views, there may be others which remain silent. I actually help you clarify. It's not really meaningful to pursue this matter. I don't think we should discuss this any further. Now, the question is not about the view of the Medical Association. I'm referring to the other part of Dr. Leung's question. I think the administration should give us more information on that. We're talking about the provisions in this bill which cross-references with the with Clause 16. So please explain to us more clearly. Yes, Mr. Chan. We can give you a written response on the impact of taking out a Clause 16. I'm sorry, Chairman, I have to leave by 6:15, so I need to go first. So if we take away Clause 16, the newly added Clause 16A will be a problem. So that's the first problem. And I'm sorry I can't wait for you to finish reading. I want to point out that as far as Clause 16A is concerned, it says, it talks about the scope of shareable data. And also 16A1B again about scope of shareable data. For 16, for the next provision, it says the type of data. So what's the difference between scope and type? After finishing 16, of course, we will come to 16A. I think the BC deliberated on the matter relating to safety box and members asked whether it's possible to have something like a safe box, and if no study had ever been conducted, how could we come up with a provision relating to the safety box? And the Privacy Commissioner then suggested that we put in a provision in this regard, and following the line of thinking of the Privacy Commissioner, we work with the DOJ, and then we have this 16A, which is annexed to the paper 808, and that is if the healthcare recipient is allowed to restrict the scope of data sharing, then he can rely on 16A. Between Clause 16 and 17, we find it appropriate to include insert 16A here, because Clause 16 is about patients, Clause 17 is about healthcare providers. We want to point out the importance of this principle. That's why we have made a separate division 3A, about sharing restriction. This new function or provision will enable the healthcare recipient to restrict the scope of data sharing. So we can allow the restrict of scope of data sharing for different types of data. For example, the patient may restrict the scope of data of sharing of 5 types of data, but not the other 4. And he may also restrict the which healthcare providers should have access to the data, and he may also impose a restriction on the type of data to be uploaded by a healthcare provider. That is why we've used the term request for sharing restriction to explain the idea of restricting the scope of data sharing. So 16A1 provides that such a restriction may be possible. So that's 16A1A, a request to restrict the scope of data sharing. If in the future the restriction should be removed, then we can rely on 16A1B, a request to remove the restriction. Because we haven't conducted the study, we cannot say for sure what the safety box should be, what the design should be, and therefore we can only provide that the restriction can be made in terms of a number of things, the types of data, the healthcare providers, so on and so forth. That is why at present we specify the type of restriction. That is 16B1. That means the Commissioner must specify the types of restrictions in respect of which a person may make a request. The types of restrictions have yet to be defined. Well, having heard your explanation, I think I need to clarify with the legal advisor. I think the terminology may be different, but I don't see a big difference. In fact, for 16A is scope of data sharings.
As 16B, as the administration said, is talking about the types of restrictions. Now, the administration says they haven't decided on what types of restrictions. So, on the scope and the types, now they're talking about different things. In that case, I'd like to ask now, if 16B is written this way, then on the types of restrictions, can the Commissioner in future stipulate that the restrictions doesn't cover certain things in the records, because types are broader than scope? Well, the scope can include many types too. It's more clear in English. Now, it's not so easy to identify the distinctions. Head HRO, perhaps you can explain again. Can you tell me what you include in types of restrictions? For instance, 16A1 is talking about the scope. Now, there are 9 types of data that to be shared, the personal data, past the hospital records, lab reports, and so on. And we're saying the future restrictions may be that there are different ways to handle these 9 types of data. So the patient might be able to withhold 5 types of data, or the patient may enable a clinic to read 3 types of data, whereas another clinic might be allowed to read all the data. So in 16b2, we use the word types of restrictions. Ms. Quek? Ms. Chai, Law Draftsman. Now, in English, as Ms. Wong said, it's clear. It's the scope of data sharing. Now, data sharing is a defined term. It's talking about the act of providing
recipients through the system. 咁係整體咧嗰個 act 嚟嘅。咁所以個 scope
So it's an act. So here we are talking about restricting the scope of data sharing. So we may not come to the specifics. Now the types of restrictions may be multiple choice, so we know which types. But as previously said, maybe the recipient is going to decide how to restrict. Right now we don't know, because the mechanism is still being developed. Maybe at that stage, how the restriction is to be exercised, the scope thereof is yet unknown. So when we come to the types, it's quite specific. So when we restrict the scope of data sharing, the patient has the power to decide the scope of the sharing. This is to provide a flexibility, so that in the design of the system, where one can allow the right to be exercised. Ms. Quek, I believe your question has been answered. There's going to be further amendment. It's not automatic. Now we are against taking away clause 16. If you are unhappy with the arrangement for clause 16, do you want to there to be a study in stage 2, so that the automatic sharing by HA and DH can be changed? Now, in respect of clause 16, we are already studying how to restrict certain persons from accessing the data. Perhaps in 16A, we can also study the same thing. So maybe you can add something in 16A, promising that in future. No, I don't think that's necessary. 16A, the restrictions would be such that the DH and HA will not automatically have access. So we have to take into account the views of the majority of the members. If they want us to study that, well, we have to study a way to offer more choice to the patient in respect of the safe deposit box already. Now, Dr. Leung Kalau is especially concerned about this issue. Now, he's out of the room right now. Perhaps the head can inform him of this to see whether he will follow up further on this. Now, we've covered 16A. Any further question on 16A? Chairman, I'd like to further confirm. Now, the head said that the 16A has received the consent of DOJ and PDPC. Yes. Now, in regard of these amendments, we are preparing letters to be sent to those who have come to this committee before, the group's deputations, so that they can respond in writing whether they have alternative views. 16AB, Division 3B, any further questions? If not, legal advisor. Now, the administration, what is the administration's thinking on the effective date of 16A and B? Will it be contemporaneous? Now, 16A is that there will be different ways for the patients to make a choice. So we have to decide on the types of restrictions first. Now, the bill already allows us to provide different effective dates for different provisions. So 16AB can await the study to be completed before we set the effective date. Now, where is that provided? Now, in the earlier part of the bill, I believe it is mentioned where it's provided that the commissioner can stipulate the effective date, the commencement date. Ms. Chai, it's in 1(2) of the bill. It's at the beginning, clause 1, subclause 2. (1)(2), yes. And in cap 1, it also says that there can be different commencement dates for different provisions in a piece of legislation. I'd like to point out to members that the administration is consistent in saying that they will go back and study about the safe deposit box before they consider the effective dates of 16A and 16B. But the provisions are written into those provisions are written into the bill to reflect the members' concern that there should be a safe deposit box. Okay, no questions. If not, we still have 5 or 6 minutes. Perhaps we can start on Division 4, Clause 17. Now, this starts on the healthcare providers. Sorry. Now, in the previous annex, 16A, is there a consequential amendment that we should talk about now? Substitute decision maker. Yes, there are 2 consequential amendments to 16A. Now, first we have to define what is a sharing restriction request. So there's been an amendment to clause 2, and then we come to substitute decision maker. Here there is one more thing for the patient or the SDM to decide. So we have to add the power to add this restriction or withdraw the restriction under the provisions on substitute decision maker. Okay, no problem. We come back to Division 4, Clause 17 is about the healthcare providers if they want to join the scheme. What are the qualifications and how they apply? Now, 17(1), it says that a healthcare provider that provides healthcare at one service location in Hong Kong may apply to the future commissioner to be registered as a healthcare provider for the system for that location. Now, some doctors have different offices. So in 17.2, we say that if there's more than one service location, then for all these service locations, he can make one request or he can make individual requests for different locations. That's what says in 17 bracket 2. And on bracket 3AB, that's about single registration or separate registration. 17 bracket 4, application must be made in the form and the manner specified by the Commissioner. And bracket 5, it says which institutions can apply. Now, there are A, B, C, D, E, F types. Now, A, that is under the hospitals, nursing home, and maternity homes registration ordinance, those registered under this institution. B is those registered under the medical clinics, the ordinance, and C is dentistry, those in dentistry under the dentist registration ordinance. D are those who hold a certificate of exemption under section 7 bracket 2 of the in respect of the residential care homes and elderly persons ordinance, and E, those who hold a license issued under the residential care homes persons with disabilities ordinance, and then there are there are entities that are not registered under A to E, and then they can make use of bracket F to register, and similarly. Now that's for now. There is also a catch-all clause, bracket G, that if the commissioner can allow that entity to join if they offer a service at a certain premises, but when we discussed with the PDPC previously, they said that this is too broad. He suggests that this bracket G should be deleted, and we agreed. We think A to F is already inclusive enough already. So you will propose a CFA to amend, to delete G. On clause 17, any question? Now, time-wise, there are 2 minutes left. Should we look also at clause 18? Okay, let's do that. 18 is very simple. Now, 17 says which institutions can join, and 18 is on how the commissioner is to deal with these applications. When he receives these applications according to 18.1, he can register them as registered healthcare providers, and when he registers the providers, he can impose the conditions that the entities have to comply with. For instance, if the institution is relocating, it has to inform us of the new address. There should be reasonable security arrangements to protect the system, and there must be training to your personnel and so on. So these are the conditions for registration. 18.1b allows these to be added. Now, on 18.2, now this is in respect of the connection or interface with our system. There are, and also there may be system requirements for their system. Now on bracket 18 bracket 18.3. In certain cases, the commissioner may refuse the application if they're under certain conditions.
Now, for example, if the Commissioner considers that the service or business nature of the healthcare provider is not consistent with the purpose of the use of data in Section 26, perhaps it is not for the healthcare purposes, then the Commissioner may decide not to register the healthcare provider. And also, if the Commissioner thinks that registering the provider may impair the security or compromise the integrity of the system, he may reject the application for registration. We envisage that such situations should be rare. Now, according to bracket 4, after refusing an application, according to 4B, the reasons for refusal should be set out in writing. If the application is approved, then the healthcare provider will be notified in writing the date on which the registration takes effect and the conditions for the registration. Dr. Lo Wai Kwok, you're the only one left here. This is quite straightforward. You have no other comments. If so, we can start with clause 19 next time. Then that's all for today's meeting. Meeting's adjourned. Thank you.